Well, howdy and welcome to TxSUS Sessions. I'm Lucas Hill, Clinical Associate Professor and Pharm Program Director at UT Austin and co-chair of the TxSUS Substance Use Symposium. Please remember to save the date for our next annual symposium on March 27th and 28th in San Antonio. And keep an eye on TxSUS.org for more information about symposium registration and content. It's my privilege to introduce our session speaker for the day, Karla Ramirez. Ms. Ramirez is the director of Be Well TxSUS, a program that offers high-quality, evidence-based outpatient treatment for substance use disorders that is grounded in compassion and built on science and improved technology. Be Well TxSUS offers virtual visits and is available to all Texans, regardless of their ability to pay. Check out bewelltexasclinic.org for more information. Ms. Ramirez has more than 15 years of executive management experience in behavioral health care, including her time as Vice President of Restoration Services at the Center for Healthcare Services in Bexar County. She has tremendous insight regarding the development of financially sustainable substance use disorder treatment and recovery programs, and we're honored that she agreed to present on that topic today. And with that, I'll hand it over to Karla Ramirez to present our session for the day.
Thank you, Lucas. It's a pleasure to be here. I'm very much looking forward to talking to you guys about a topic that comes up, I think, for all of us. And we tend to focus a lot of our energy on the clinical aspects of what we do, but discussing sustainability and trying to figure out ways that we can better serve folks and also maintain our programs, I think is a conversation that we need to be having more and more. And also right now is a great opportune time for that, given the current climate and the current needs. And also for substance use disorder and behavioral health, there's quite a bit of focus on that right now. And I don't know how long that's going to last. So thank you very much for having me. And I hope this information is helpful and useful to you. So what we're going to talk about today is, I think the first thing that's really important is parity and what parity laws did and continue to do that have been really transformational for our ability to bill for services. There has historically always been quite a bit of inequity related to behavioral health and physical health services and how they were reimbursed. And this has been a really important piece for this talk and just for the field in general. Then we'll talk just a little bit about Medicaid and Medicare coverage for SUD-related services and some ways that you can maximize those revenue streams, even though we do have quite a few limitations, but there's ways that you could be creative, and we can talk about some of that. And then lastly, which is kind of my area of passion right now, is figuring out how to increasingly do value-based payment models, which is really just the idea of getting paid for quality. And as many of you probably know, substance use disorder services, a lot of the things that are very effective are not things that are traditionally covered by fee-for-service. And so when you're able to develop programs that are effective by using this array of services and you can demonstrate outcomes, then value-based services and contracts allow you to do that. Right now, with substance use disorder, there's quite a few issues during a time where there's like a microscope on it, right? There's access issues, there's fragmentation related to our systems, there's coverage issues, right? We didn't expand Medicaid, and even though we do have parity in place, there is still quite a bit of difficulties in terms of getting coverage for your services. And then we have capacity issues. We don't have enough providers that are able to provide the service, and the providers that do are frustrated with the compensation and reimbursement rates that currently exist. And of course, there's the discrimination, right? You would think in our healthcare field that that would be an area where we wouldn't have discrimination, but actually research has shown that that is one of the areas that our patients tend to experience quite a bit. So like they'll go to the emergency room and they'll be seen as, drug seeking, right? And so a lot of times they're just less likely to share what's going on. And if you just look at cost, there was a Milliman study that was done, and they looked at 21 million claims for folks that had behavioral health issues. And what was interesting about that was that they found not only that the majority of cost was a small percentage of folks, the cost was not in behavioral health services, the cost was in the physical health services. So traditionally, companies would look at, behavioral health patients and look at their behavioral health cost. And in the study I'm referring to, the average cost was like $95 per patient. So you'd be like, oh, they're not expensive at all. But then when you went and looked at their physical healthcare cost, that's where there was an enormous difference in cost. And so now insurance companies are looking at that more closely, and it has a lot to do with parity. Next. Okay, so what is parity? Parity was not just a law, it's a bunch of laws. But in Texas, most recently, the laws that have been passed, and I'll go into the specifics of them, have really helped with enforcement. But really the point of parity is to help provide protection so that people with mental health and substance use disorders have the same treatment and services as people with physical health conditions. So that means that an insurance company has to cover your substance use disorder service in the same way that they cover your doctor visit for your flu or for your diabetes or for your asthma. And so no more can they be more strict or try to make you jump through hoops the way that they used to do. And if they do that, now there's quite a bit of accountability built in that, that you can certainly hold them accountable. Okay, so it's a pretty complicated amount of different laws that were passed. So I'm not going to go into every single thing, but this actually started back in 2006, if you'll believe it. But the first law that was passed, which is the Paul Wellstone and Pete Domenici Mental Health Parity and Addiction Equity Act, that was the one that was a federal legislation that really was the one that came in and said, you can no longer if you're going to offer a mental health SUD benefit, it cannot be any stricter than your medical surgical benefit. But it was a very vague law. It had a lot of loopholes and things. And so while it was a great first step, there was a lot of ways that insurance companies were able to get around it, right? Through medical necessity requirements and through just different ways that they were able to still make it more difficult for people with SUD or behavioral health issues. So then came Affordable Care Act. And what Affordable Care Act did was it said, okay, if you're going to be an insurance company that's going to be part of, the large insurance companies, then you're going to have to cover these 10 essential health benefits. These are just basic things you're going to have to cover. And mental health and substance use disorder services were added. So that was a huge step forward for our field, and really a step towards recognizing that mental health and substance use disorders are a physical illness and should be seen in the same way as other physical health concerns. And I really like it because I think that it makes us see it as we're moving towards healthcare, including our physical, our mental health, and it's all becoming one. So that's my dream one day, is that health mean all of it. Then in Texas, which came more recently, I think HB 10 was passed in 2017 and HB 2595 was passed like in 2021. I might be wrong about that. But what these did was these focus more on accountability for implementation. And so these require that we have an ombudsman, that we have a way for a consumer to make a complaint if they feel like the parity is not being followed. And we also have now the requirement to have a portal. So now complaints will be public. So there's been quite a bit of enforcement, and I think people maybe don't know that much about parity, but it's a very important piece to sustainability and has opened the door for that. Okay, so why is parity important? Parity basically says that when it comes to QTLs and NQTLs, quantitative treatment limitations and non-quantitative treatment limitations, there cannot be a difference between medical surgical benefit and behavioral health benefit. And these are the specific things that cannot be different. So financial requirements, treatment or service limitations. So, if your outpatient medical says, you don't need pre-authorization for it and you can have unlimited, then your outpatient behavioral health has to say the same thing. Same thing with out-of-network benefits, which for behavioral health is a big issue because we don't have appropriate networks like we do on the physical health side. Prior auth is a big one. You used to have to get prior authorization for almost any behavioral health service. Now, most outpatient services, you don't require that, not even for medication-assisted treatment, which is a big step. Medical necessity requirements cannot be more stringent than in physical health. And then the fail first requirements, I know that in other places, it used to be, if you're going to qualify for this level of care, then you have to show that you failed in this level of care. So all of those things are no longer allowed. So sustainability planning is key to all of our work. We definitely want to continue having prevention and harm reduction, treatment and recovery. And we didn't expand Medicaid, so we don't have the ability to have a comprehensive system of care for about 20 to 30% of Texans that don't have any kind of funding. And so it's really important for us to figure out ways to maximize our resources so that maybe we can take care of those folks that don't have funding because we've done such a great job with our sustainability. So some of the strategies that are, I think, important when you're thinking about sustainability and that I've found to be very effective. The very first one, the most important one, and the hardest one, I would say, is documenting your effectiveness and measuring your outcomes and demonstrating your outcomes, showing that what you're doing is effective and it's making an impact and it's specific and measurable. That's going to be important in no matter what agreements you're doing. Strategic partnerships. So an example that I could give you is, if you currently have a program that's funded by a grant and it has proven to be extremely effective in reducing utilization of high-cost care, maybe reducing emergency department utilization, and that grant is going to end. Maybe if you can demonstrate that and you can demonstrate the ROI and the reduction in cost for that healthcare provider, that healthcare system, maybe there can be discussions about them supporting this program moving forward. So there's those kinds of things that can happen. You definitely want to recruit support from your community, your family, the families in those communities, and key leaders in elected positions that can influence what happens in those communities and can help make sure that funding can get secured. And then what we're talking about today, develop sustainable funding models for this. So when you're talking about funding, we're talking about a bunch of different things. It's very confusing. Many of you are really good at this already, but some of you may not know that much about it. So we have Medicaid, Medicare, TRICARE. Those are the three governmental type of insurances. So Medicaid tends to be for people that are indigent, people that are like women and children that are pregnant and parenting, and so on and so forth. We have Medicare, which tends to be for elderly populations or for disabled folks. Then you have your people that are what are called dual eligibles that tend to be disabled or also are elderly and are also poor. And so they get Medicare and Medicaid. TRICARE is the military systems insurance, and TRICARE tends to follow a lot of what Medicare does. And then you've got your private insurance, and your private insurance companies have their private products, and many of them also have Medicaid products and Medicare products. And so it is really confusing on how to navigate this system. But once you figure out how to do it, you really can be innovative and figure out ways to create revenue. And then, alternative payment models, which is the newer thing for our behavioral health side of the house. But in the physical health world, they've been going on for a little bit longer. And I'll talk more detail in a minute. Next. Okay, so this is it's a very small slide, but just gives you an idea of all of the different possible things you can bill for Texas Medicaid, right? And what you'll see in here, and there's a second page to it, but what you're going to see is we can bill for all different kinds of services. And in most behavioral health programs, we do provide quite a bit of these. So in 2010, when Medicaid first started covering substance use disorder, we had to get real creative on trying to figure out, how can we make sure that we're maximizing our revenue and getting paid for the services we're providing. Otherwise, we're not going to be able to cover the cost of doing this, right? And so, most programs or many programs, besides the SUD treatment services or psych treatment services, they're providing some medical services as well. And a lot of times we forget that. And so medical services are also billable, and you can bill for those things too. So it's just really important to, when you're creating your billing systems and identifying what services you provide that are billable, to make sure that you are not just following the typical list of, okay, the SUD benefit, it's this, 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 and this, but really trying to look at your services in a comprehensive way, and what are the things that you're providing that are also billable. Many times people will say, oh, like peer recovery support, it's billable, but it hardly pays anything. Okay, that's true. But if you're still providing it and you've got a Medicaid population, it still can add up. So that would be a recommendation I would make. Bundles. There's also the ability to have bundled rates. And these are rates where you're getting compensated for providing a service array and getting paid a daily rate for that service, or a weekly rate. So it'll say, like PHP is a good example. For partial hospitalization, you get paid this much per day, and the expectation is that the patient receive this many hours of services with the minimum of this, 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 and this. So those are bundled services. Next. So Medicare, interestingly enough, parity does not apply to Medicare. But Medicare is moving along with their reimbursement for substance use disorder. They have a long way to go, but they have made some strides, especially recently, especially specifically to opioid treatment. But these are the kinds of things that Medicare does already pay for. You've got SBIRT, you've got your prevention services, you've got your opioid treatment programs. And the good news about those is that the rates are pretty good. And so you can do well with Medicare patients if these are the services that you provide. Now, if you have services that you want to provide that are not things that are already in this list, then that's when you want to start thinking again about these alternative payment models. Okay, so alternative payment models are really focused on financially incentivizing providers and payers and other stakeholders to treat people with a substance use disorder as if they have a chronic condition that needs to be managed. They're value-based and they're outcome-driven. And so really the idea here is similar to chronic disease management for diabetes. You're looking at this as a chronic disease and something that needs to be managed over time, not as an acute service kind of response. Next. So the one that I'm going to talk about today, although there's quite a few going on, but the one that I'm working on and doing and getting a little bit specialized in, I guess you would say, is the addiction recovery medical home model. And what this is it's very patient-centered. And really the focus here is improving quality and reducing costs for folks that have substance use disorders by creating a medical home model for people with substance use disorder issues. And the idea here is that recovery can be long-term. So the model, the one that we're working through is a 5-year plan for an individual. Because basically, if you've heard some of the discussion, sometimes people look at recovery the way that they look at cancer. If you've made it 5 years, then you have a much higher chance of sustainable long-term recovery than under 5 years. So the idea here is improve quality, reduce costs, increase access, right? And by increasing access, that doesn't just mean, like somebody's insured, so now they have access. It really means ensuring that the individual gets access and really engaging with that person to make sure that the service delivery and the infrastructure that is built is responsive to the needs of the individuals being served. So you want to make sure that you have all of the different components that will be proven to be most effective. And sometimes that includes non-traditional things in our field. And then we want to create sustainable coverage and payment strategies, right? So that hopefully we can not be only trying to live off of grants and federal monies. Okay, so the foundational elements about this addiction recovery medical home is you've got the payment model aspect of it, which looks at things as episodes of care, and with the ability to also get rewarded for performance bonuses based on quality metrics. So the idea here is not, oh, I provide this service, I get paid for that. I provide this service, I get paid for that. This is really a per patient per month, per patient per day, or, in a larger scale, if you had the numbers, it could be for this whole population, right? But the idea here is that you're getting paid to take care of this individual based on their needs, whatever it takes to ensure that you meet these quality metrics that have been identified. One of the challenges that has come up for substance use disorder, and it's something that we as stakeholders in this field should really come together on, is really defining what those quality metrics should be. Traditionally, in previous times, it was very focused on abstinence and things like that. And now there's been a shift more towards looking at functionality, right? Quality of life. Is this person able to seek employment and maintain it? Is this person able to engage in meaningful activities? Things like that. But those things are a little harder to measure sometimes. So quality and process metrics, like I said, recovery capital metrics is one that that has been proven to be useful for when you're looking at recovery support and those kinds of services. So central to this model is this care recovery team, where you have a care coordinator at the center of this. And what that individual is doing is really ensuring that this individual is engaged and that the services are being coordinated. So this addresses that issue of fragmentation that I mentioned earlier. And then we've got a treatment and recovery plan. And the idea here is that the individual, when they're enrolled in this, at that moment, there would be an assessment and there would be a individualized plan that would be developed that this person would participate in. And then, of course, you would have to have a pretty comprehensive network of care to be able to ensure that the individual is able to, you're able to coordinate other types of care. You want to be integrated. So you want to make sure that primary care is being addressed. And so, you know, what FQHCs are in your area and what other types of providers can you work with to ensure that you're able to help the person get all of their other needs met, because if they don't, then they're not going to be successful in their recovery. So how does this work? So I'm going to try to simplify this as much as possible, but the way that this works is you'll start at what's called, you know, pre-recovery and stabilization, which is not part of the model, right? And this is your high level of care services. This is an emergency room. This is a psychiatric hospital. This is residential treatment. This is where an individual, you know, is admitted and it is identified that they would be a good candidate for this arm. So what would happen is that would be identified based on certain criteria, and they would be offered enrollment in this arm. They would be enrolled and they would enter what we would call episode 1, which would be initiation of active treatment, right? And so for episode 1, it's a 0 to 12 month period. And you're going to have folks that probably are moderate to severe in their illness, and you could create payment rates based on those levels, mild, moderate, severe. And their service array might be different, but it's basically, if you just want to think of it in a general way, that you're talking about like your pretty intensive outpatient services, IOP, PHP, those kinds of things. Or outpatient, but with a lot of other additional supports. And what I like about this is that, you know, you've got a year, and that's quite a bit of time to be able to really work with somebody if you're able to keep them engaged by providing peer recovery support and other types of services that that you could do to enhance the more traditional types of things. Then you go into episode 2, which is community-based recovery management. So the idea here is for the next 5 years, you're working with the individual to sustain the recovery, right? And so your payment rate's going to be a lot less, but also the cost of the services are going to be less, but they're going to be more responsive to the needs at that point in time. And there you're talking more about social engagement in meaningful activities, support, and things like that. And so, so the service array might be different, and but also effective. Now, the risk piece comes in where if you have an individual in episode 2 and they end up needing an episode, like going back into episode 1, you will not get paid at the episode 1 rate. You will only get paid at the episode 2 rate. And so the provider has a lot of incentive to make sure that the individual is receiving what they need to stay in episode 2. And that's the part that makes people really nervous. So the payment. So if you look at this, so pre-recovery and stabilization, like I said before, that stays how it is. It's fee for service, and it has nothing to do with this model. But after the person is identified, then, you know, you have this bundle payment, episode of care payment. There's different ways that different companies like to do it, but basically it's a payment at a higher rate. Sometimes they like to do it as fee for service, but after the fact, we'll pay you this additional money. But it's more ideal if you're able to get to some sort of episode of care rate, or a bundled rate. And both of these phases, you are eligible for quality adjusted payments and performance bonuses. And those are things that you would negotiate individually with each company when you're in that point of negotiations. And then once you get to community-based recovery, it's still the same type of payment. It's a bundled payment, but it's a declining payment. And so the tricky part for this is figuring out what those rates are going to be. If you're a more sophisticated organization and have been around a while, like if you're like a longstanding MHMR, you probably have a lot of data to demonstrate your cost and your probably per person per day cost, your per minute per day. I mean, you probably have lots of ways that you break down cost. And so it might be a little easier to figure out what those rates should be versus maybe another organization that's a little newer to this. And so figuring out what those rates should be is one area that I would say I've also struggled with, and I think most people do. There's lots of ways that you could go about that. You could map out, okay, somebody in recovery initiation, active treatment in general, this is what they would normally get in fee for service, right? This is what we'd like to develop. This is what the fee for service rates would be. You could map it out and try to get an idea, and then maybe say, okay, in 12 months we reevaluate, so that you're not stuck in a six-year contract and you find out in a year that you're losing your hat and you should have just stayed with fee for service. But like I said, the idea here is we want to create a way to have coordinated and integrated care for the individual. So we want to make sure that they're getting their physical health and behavioral health needs met, and also that they're getting the wraparound services that they need, and that there's a financial incentive to do that. So there is precedence for this. There's other folks that are doing this. This slide is a little bit dated, so there's probably more now. But here in Texas, Superior has got quite a few APMs that they're doing for substance use disorder specifically. And if you're interested, I would certainly recommend that you look some of these up and just read a little bit about it if you're not already familiar. And I'm also happy to have any discussions or provide any kind of resources if any of you wanted to reach out and ask questions or ask for resources. So this just kind of shows you what the guidelines are. Okay, what is the payer's role? What is the care delivery partner's role? And so if you were doing this with a Medicaid managed care population, really what the Medicaid agency would be responsible for would be, definitely participating in the partnership, coming up with a payment strategy, figuring out a way to share data, and building a sustainable infrastructure to be able to do it. Whereas the care delivery partner, which would be us, would have to make sure we had the provider capacity, that we had the relationships that would be needed to do something like this, that we also develop and implement information sharing systems, which is hard sometimes, and that we make sure that integrated and coordinated care is provided. And of course, the quality data is a critical component. Okay, that's it. So I hope you guys found this interesting. This is an area that I'm very passionate about, and does anybody have any questions?
Hey, well, thank you again, Karla, for presenting on this topic. And we've got some good questions in the chat. So I just first want to acknowledge one asking about a copy of the presentation. So a PDF copy of the presentation is now available in the learning management system online. So if you log in to complete your evaluation, or just because you already registered for the event, you should have access there. But also remember to complete your post-session evaluation in order to obtain continuing education credit if you're looking for that. That'll be at the same link. Then I think a couple of questions for us beginners. Initially, with programs that are trying to get alternative payment models off the ground, or do a better job of providing the type of care that would be conducive to some of these payment models, are there specific staff that you often see them needing to hire, or roles that they need staff to fill, to shift to fill? That could be clinical or administrative.
That's a good question. Yes, I mean, critically important to a model like this would certainly be that you have the care manager or care coordinator in place, because that person would be making sure that if you don't provide some of these services, that you are making sure that the individual's getting those services, right, from other providers. So that would be very important. Also, peer recovery support services or access to them, very important. So more at the clinical level, these are the things that I would say would be most important. But certainly administratively, there is quite a bit of time that it takes to do these. And so you definitely want to have somebody or consult with somebody that knows how to do contracts with managed care, and have somebody that's in an administrative function that is interested in it and that is willing to do some of the work, because there's a lot of paperwork and things like that. And then the data piece, having that infrastructure or the ability to build it should you get one of these, because the compensation will pay for it, but you just do have to have the capacity to build that infrastructure.
Okay, and then you provided a lot of really, I can see why people want the slides, because you provided really specific codes that are going to be helpful. But one question we got was, in order to bill Medicaid for all those codes that you listed, do we have to go back to the MCOS and negotiate having those included in our contract? Are they included by default? Is there any sort of additional background work that's needed?
That's a good question. The contracts are so different that if you're talking about MCOs, it's really going to depend on how your contract's written. If it's specific to codes, and not categories, then possibly yes. And you might want to look at in the future expanding those out a little bit in your contracting more generally.
All right, another really good specific question. Is the addiction recovery home model able to cover recovery housing costs during phase one? And have you seen much interest from local managed care organizations to participate in this type of model? If not, who else would fund this for most participants, given that Texas is a state that chose not to expand Medicaid?
That's a great question. So the recovery home model and what could be included and what could not be included is very open. And so when you are deciding to do this, you want to develop a really good proposal. And just like we've kind of done with ours, it starts with an idea that you think is going to be effective. If you already do this work and you can demonstrate that it's effective, even better. So if you're able to show that through your work and recovery home has made a difference in especially cost for healthcare that is more expensive, then you can certainly negotiate that in these cases. We have seen quite a bit of interest from the insurance companies. It is varied when you're talking about MCOs versus private insurance companies. And also there are different levels in their readiness for that. So this isn't a fast process. This is a long process, and it's a collaborative process. And so my recommendations is really to just get started and start thinking about, what could we design and who could we partner with to get these conversations started if you're not having them.
Another great question, this time from Sierra. Can you speak to how non-clinical settings like recovery community organizations might interface with alternative payment models? How could an alternative payment model facilitate building infrastructure for groups from the community and clinicians to collaborate?
So RCOs are going to be a critical component to this model, especially for phase two. And so there's no question that there's huge opportunity there for these, for RCOs and for peer recovery support providers, individuals, and as a field. So how that will work for each different model and each different group is going to probably be different, but certainly there's no question. And so if you are an RCO and you have interest in this, you can always go to, some of your healthcare providers that you work with that do some of the clinical work that would be considered the phase one and say, hey, could we work on this? And hopefully they would say, yes, let's do that. And you just never know. That's how we started, with just having conversations.
And we got a question. How is or can concepts of equity be built into these alternative payment models? How do you guard against adverse selection? This person, they're knowledgeable. They cite a reference showing that Medicare's experience with accountable care organizations led to some, regressive outcomes. I know certainly in Texas, programs that are funded with grants can stretch and apply to other folks. But how can you see that continuing after maybe some of these block grants are gone?
Well, yeah, that's a great question. So so, in Texas, we had just have this 20%, depending on what data you're looking at, but 20% of folks that don't have insurance, right? And unfortunately, those 20% are also the 20% that are also they don't, they live in the areas that don't have the resources, and they're also just tend to be subject to all of the other inequities that we talk about, and they tend to be less healthy. And so there's just and these models would not apply to them because they don't have insurance, and these are for people that have insurance. My hopes is that through kind of enhancing our array of funding, that we build some of these other models so that we can continue to serve these other folks because of that. And so that's kind of the goal is, we are very, very dependent on, our state and federal money, and we continue to, desire that, and we hope that it'll continue, and we're continuously writing grants. But in addition, we want to build these other sustainable models so that at least those percentage of populations, we can create ways to kind of cost share in a way.
Yeah, that makes sense. I'm learning as you're. No, I think it makes sense. It's a system built on insurance, so we get what we get. But it's another great argument for why it seems, at least in the case of Texas, like a really positive thing that these state opioid response dollars have gone to public universities that ultimately are founded upon this concept of providing community service and have an incentive to use funds not as profits, but to reinvest in the care of other patients who might not be covered. But it is an interesting challenge with the system. So thank you for that question.
It really is. If you go to other states that have expanded Medicaid and you see what they've been able to build in our field, it's so incredible. They have very comprehensive systems of care and very collaborative ways that they serve folks. And they have, the healthcare in the housing facilities, and it's very different. And hopefully one day we'll get there, but.
And I think this might be the last one. Is there any documented example of an addiction recovery home model reimbursement package that has been negotiated in Texas? The insurance coverage is so fragmented by state, and it seems like it's the kind of thing that you would really need to be a big program with a lot of patience, a lot of power in order to get an insurance company's attention to say, here's our package. Is this something that y'all have gone through specifically at Be Well Texas, or that you know of other systems that have? And are there any templates or maybe a way for other groups to sign on to it, or to follow the example if they already have a lot of services within their program?
That's a good question. So yes, and yes. We don't have that existing toolkit or anything like that. There are some resources out there. We have gone through this process and are going through it and learning. And so we would be happy to share, what we've learned from it, what we know, where we've scraped our knees. And also certainly if there's folks that would like to partner with us and be part of that network, we want that. We want that across the whole state. So we're not being greedy. We definitely want to share in this, and the more expansive our network can be, the better it can be. And we're happy to figure out, payment and those kinds of things. But that'd be great. I would love to create, maybe we need to create a toolkit of some sort.
All right. Well, I just want to thank you all for spending this hour with us, and thank Ms. Ramirez again for presenting on this topic. And don't forget, you can download the PDF of the slides, and you can also complete the post-session evaluation to obtain continuing education credit. We'll see you in San Antonio, March 27th and 28th for our annual symposium. Keep an eye on TxSUS.org for more information about the content and link for registration. See ya.